Chronic back pain, especially the kind that sticks around after surgery, it's one of the toughest problems in medicine. But what if a single procedure could rewire that entire experience? Today, we're looking at a seriously groundbreaking surgery that's trying to do just that. And just so you know where we're getting this incredible info, this whole explainer is built on the sharp, insightful review by Dr. Reza Lankarani. He's a general surgeon and the founder of the Surgical Pioneering newsletter and podcast series, an absolute expert in the field.
Today, we're heading straight to, well, the operating room. But this isn't your grandfather's surgery. Not by a long shot.
No, not at all. We are exploring a really thrilling convergence of traditional structural medicine and some very advanced neurotechnology.
And we're going to focus specifically on how innovators are tackling one of the most just, stubborn human ailments there is, chronic low back pain.
That's exactly right. For years, we've relied on structural fixes, for spinal problems. But those fixes, they don't always translate into lasting pain relief.
Right.
So our deep dive today is centered on a pretty radical integrated approach. It's known as the SynerFuse ULE procedure.
And that merges physical repair with, what, targeted nerve stimulation?
Highly precise nerve stimulation, yeah. And the name really spearheading this innovation is Dr. Rohan R. Lall.
So our goal for you, the listener, is to understand why this approach is, considered such a major leap forward, what specific technological hurdles it overcomes, and why its early results are giving so much hope to patients.
Especially patients who have really exhausted the traditional options.
Absolutely. So to set the scene, let's quickly talk about Dr. Lall's background, because that really provides the context for this level of innovation.
It really does. He's a neurosurgeon based in Edina, Minnesota, and he's affiliated with some pretty significant institutions like M Health Fairview University of Minnesota Medical Center.
And his clinical scope is it's immense.
It really is. We're not talking about a surgeon who only does routine
And back fixes, yeah.
Exactly. His practice spans complex spinal procedures, things like fusion for stenosis and spondylosis, all the way to brain and spinal tumor resection.
And even highly specialized skull base and pituitary tumor surgery. I mean, that's a whole other level.
That breadth is key. Dr. Lall operates where the stakes are highest and the technological demands are just the greatest. He's been a leader in robotic spinal surgery development, and critically, he serves as the chief medical officer at SynerFuse.
So this isn't innovation being handed to him. He's driving it.
He's driving the development from concept right through to execution.
Okay, let's define the specific medical challenge that this technology is trying to solve. We know traditional spinal fusion is good at stabilizing the spine, but it sometimes fails on the pain relief part.
Yeah.
So who is the target patient here?
We're targeting patients suffering from chronic, often really debilitating low back and leg pain. And this group includes, two main categories. First, those who are candidates for spinal fusion to begin with, but maybe more significantly, those patients who are suffering from what the medical community calls failed back surgery syndrome.
Ah, failed back surgery syndrome. I've heard of that. That's when the discomfort just persists, right? Sometimes it's even worse than before, even after a structurally successful surgery.
Exactly. The fusion might be biomechanically perfect. The structure is fixed.
The hardware is in place. Everything looks good on an X-ray.
Perfect. But the patient still hurts. And this is often because chronic pain has this substantial neurological component. The nerve root might still be irritated, or the spinal cord itself has become sensitized.
So it just keeps firing those pain signals.
It keeps firing them long after the physical issue has been resolved. The brain basically learns the pain, and that neurological message just overrides the structural fix.
So if the pain is there because the ultimate messaging system is still faulty, the breakthrough is structural.
And that brings us to the SynerFuse ULE procedure, or the ETLIF.
ETLIF, okay.
It's a dual-action approach. It seamlessly combines that conventional spinal fusion with targeted neuromodulation. The conventional part, that's the TLIF, transforaminal lumbar interbody fusion.
And what does TLIF mean in practical terms for the patient? What's happening in the OR?
It's one of the really common ways to fuse the spine. The surgeon works through a corridor to remove the damaged disc, and then they insert a structural spacer, a cage, to promote fusion between the vertebrae. It's a workhorse procedure.
A real standard.
A real standard. The innovation here is the ETLIF, where that E stands for electronic or electric. They are integrating the neuromodulation device during the standard fusion, right within that same surgical corridor.
Oh, that's clever. That spatial integration is critical. It's not just a traditional spinal cord stimulator that you might put in later on.
Right.
This device is integrated right where the source of the problem is being fixed.
Precisely. And the technology is classified as UA therapy, which stands for ultra-low energy. This is important because it implies a very targeted, precise stimulation.
So it's not like a big electrical field.
No, it's not the high-power, broad-field stimulation of some of the older neuro devices. It targets the affected nerves with minimal energy, which helps the battery life and, potentially reduces side effects.
And Dr. Lall's involvement here goes way beyond just being an early adopter. The sources highlight that he wasn't just an investigator in the proof-of-concept trial, but he actually pioneered the procedure itself.
He did. He performed the world's first solo and the first two-level SynerFuse ETLIF procedures.
Wow.
That kind of intimate involvement from conception to the very first complex execution, it just shows a profound commitment to pushing the envelope.
So let's dive a bit deeper into the mechanism. If the fusion is rebuilding the unstable structure, what exactly is the neurostimulation part doing?
Okay, so if we use an analogy, the fusion is like rebuilding a damaged bridge.
We are truly pioneering the future of
running
spine
across
surgery.
that bridge is
This technology
a
represents a
noisy
significant
electrical
leap
cable.
forward
That's
in
the
patient
chronic
outcomes.
pain signal. And it just keeps transmitting static to the brain.
That's really good.
The implanted nerve stimulators, they fundamentally alter the nerve stimulation. Essentially installing a highly specialized camera
Technology,
or filter
SynerFuse
on
UI,
that
represents a
cable
significant
right at the source.
advancement in
Preventing
spinal
the message from
surgery,
even getting
offering
through.
improved fusion and
We are
patient
moving
outcome.
beyond just biomechanical repair and actually correcting the pathological neurological signaling that, defines chronic pain.
This raises a big question for me, though. Integrating two really complex procedures, a fusion and a neuromodulation implant, that must increase the surgical time, the risk of complications.
That is a fair and a very necessary question. The efficiency really comes from the design.
In spinal surgery,
SynerFuse
offering improved
devices
integration
designed
and
to be
patient
placed during the
outcomes.
existing
This technology
PLIF
allows for better
approach.
fusion and
They're
stability,
using
which
an
are critical in
established
these
surgical
procedures.
window.
So no separate incision, no separate procedure later on.
Right. They're not creating a new problem to solve. And that ULE classification suggests the device itself is likely low profile. It's integrated into the fusion hardware pathway, so it reduces that added surgical burden. The efficiency is a key part of the value proposition.
That makes a lot of sense. Using the existing corridor is a really smart design choice. Now let's talk about the tangible impact on the patient, because that's really what matters. What are the reported benefits from the early trials?
The initial findings are, they're highly promising, and they focus heavily on patient satisfaction and quality of life. One really fascinating feature is the patient control aspect.
Oh, yeah.
The implant allows patients to manage their own nerve stimulation through a smartphone interface.
So the control over their pain management is literally in their pocket. That must give patients a massive sense of agency.
Absolutely.
Our region,
And
which is
beyond
crucial
just
for
control,
maintaining
participants in the
stability
trials reported
and reducing the
significant
risk of
pain
adjacent
reduction
segment
and
disease.
substantial improvements in their overall quality of life. They aren't just reporting, slight relief.
They're reporting actual gains in function, mobility,
Daily enjoyment, things like that. And crucially, we have to talk about the opioid connection here.
Yes. The sources really stress this as a key benefit, achieving that pain relief without long-term opioid dependence.
This point cannot be overstated. I mean, chronic post-surgical pain is a major, major contributor to long-term opioid use.
It's a huge driver of the crisis.
It is. So by interrupting that pain signal transmission early and effectively, this technology offers a pathway to break that cycle. For patients, this means avoiding the severe risks that come with dependence. And for the healthcare system, it represents a profound clinical and, frankly, economic saving.
The ability to manage severe chronic pain using this dual modality approach, it could be a revolution in prescribing.
Structure plus neurology, yeah.
That's truly the societal game changer here. Now, since this is cutting edge, we do need to apply that critical lens and discuss the current status and the evaluation. This procedure is still in its preliminary phase, right?
Correct. We are talking about preliminary studies, involving a limited number of patients. So while the initial results suggest a huge step forward in spinal care, researchers are taking a very methodical approach to gathering that long-term data.
What does that rigor look like on the ground? How are they proving its sustained effectiveness?
Well, the long-term effectiveness is assessed primarily through continuous patient pain scaling and functional reporting. This isn't just a one-time check-in.
Right.
Researchers have to continuously track these patients over several years, often 3 to 5 years, to make sure the approach maintains its efficacy and that the hardware holds up.
So they're looking for sustained relief. They want to ensure the body doesn't eventually adapt to the stimulation, or that the chronic pain messaging doesn't somehow find a way to reroute around the device.
Exactly that. The complexity of combining these therapies requires really vigilant assessment. And while the sources indicate no specific major complaints have been reported in the early data, managing the risks associated with any implantable technology, you have electrical components combined with the stresses of a surgical fusion, that's an ongoing process that defines this research phase.
Let's shift to the broader context then. Why is this combined modality approach so important to the future of spinal surgery, even when you compare it to existing methods like, say, standard spinal cord stimulation?
The novelty is really in the timing and the depth of the intervention. Traditional neurostimulation often comes after the structural fix has failed. It's a rescue attempt.
Right, it's a plan B.
It is a plan B. The SynerFuse ULE procedure integrates the neurological solution at the time of fusion. By stabilizing the spine and dampening the pain signals at the same time, they are hoping to prevent the development of that chronic nerve sensitization from the very start.
It sounds like proactive pain management that's literally built into the repair process itself.
Precisely. It is tackling the structural problem and preventing the neurological sequelae, the complications that follow all in a single surgical setting. And that represents a fundamental shift in how we approach the treatment of chronic low back pain.
Moving toward highly
In
personalized
spinal surgery, offering improved integration and patient outcomes.
And it makes
This technology
perfect
allows
sense
for
that
better
an
fusion and
innovator
stability,
being
which are
driven by a
critical in these
surgeon
procedures.
whose own practice is incredibly demanding.
It does. Dr. Lall's experience in complex spine and revision surgery means he has seen firsthand where the traditional methods break down.
Absolutely. His complex caseload is sort of the ideal crucible for generating a solution like SynerFuse. His expertise in robotics and high-level neuro-oncology, brain and skull-based tumors, it just confirms his comfort in capabilities right in that interface of advanced tech and intricate human anatomy.
So it's not just a niche fix. This is an innovation that's coming from a place of deep, system-level understanding of surgical failure points.
That holistic view is essential. When you're developing new implantable technologies, you need expertise not just in the mechanics of bone and joint, but in the subtle nuances of neural signaling and tissue interface.
So let's synthesize the core takeaway for the listener. What is the big picture here?
The core idea is that the SynerFuse ULE procedure represents a true advancement in integrative surgical medicine. It symbiotically marries the structural stability you need from a fusion with the neurological solution of targeted stimulation.
It's a dual-action approach that's intended to interrupt that pain cycle, maybe permanently.
That's the goal. It's a promising new door for that really difficult group of patients suffering from persistent post-surgical pain. And, it's a strong indicator that the future of surgery is becoming more and more neurological.
Yes. We see a promising start in the preliminary data, but the crucial work is now the ongoing, rigorous, long-term data collection based on patient outcomes.
It's an innovation that demands our continuous attention in the coming years, for sure.
And finally, based on the really detailed mechanism we've discussed today, this ability to fundamentally alter nerve transmission using ultra-low energy stimulation, we want to leave you with this thought.
If we can effectively and precisely intercept or alter chronic pain signals at the spinal level, what possibilities does this open up for treating other chronic, hard-to-solve conditions beyond just the spine?
Things like complex regional pain syndrome.
Or severe forms of diabetic neuropathy, or even certain persistent post-herpetic neuralgias conditions driven purely by, erratic or chronic neurological signaling. Does this technology pave the way for a whole new generation of highly targeted neurological filters? That is the exciting question this combined surgical and technological breakthrough raises.
Yeah.
And again, we want to give credit where it's due. This deep dive was based on the really profound review by Dr. Reza Lankarani, who is also an editorial board member for the Genesis Journal of Surgery and Medicine. If you want to dig even deeper, you can get more details from the Surgical Pioneering podcast series application. You can find it at surgicalpioneer.codeadx.me. Thanks so much for tuning in.